Good morning, everyone. So I'm going to record my presentation within the ESNT conference with some modifications. So I added to this recording some another slides. To start with, I would like to thank and appreciate the efforts done by the ESNT board. Congratulations, Professor Hana Hafiz, the president of ESNT, and Professor Amir Rifai, the Secretary General of ESNT and the scientific chair, and Dr. Amr Hussein for the best organization for the meeting. I'm very happy and glad because it seems that this year, ESNT conference is more successful. To start with, do we need research in nephrology? Yes, we need research in all specialties in medicine. Why? Because medicine is the science of uncertainty. So long as we are dealing with uncertain medicine, this means that we have a lot of gaps. And the idea is to fill the gap. How to fill the gap and answer the questions is to have research. In nephrology, we are in bad need for research. Why? Because as you see from this Lancet paper, mortality associated with CKD is enormous. 1.2 million people died globally from CKD, according to the 2017 data. And this slide shows different etiology associated with mortality according to the age range. AKI is not innocent. AKI is associated as well with mortality and morbidities and development of CKD and end-stage kidney disease. This is why we need research to improve the nephrology practice. Do we have enough research in nephrology? The answer, no. We don't have enough research. We don't have sufficient amount of research from the quantity and from the quality aspects. If we compare nephrology and expanded kidney means this is the red colored kidney expanded, and the blue one means kidney. So this is nephrology, and this is renal replacement therapy. If you compare these together with other specialties like nervous system and cardiovascular system, you will find here nephrology lies in the bottom according to the number of randomized controlled studies done through the last 7 decades. Although in the last years there is some improvement, but still we are in stagnant. So we are in stagnant, and we need to improve quantity and quality of research, because according to this study, quantity and reporting quality of kidney research can be further improved. Another interesting point is the transparency and the reproducibility of research in nephrology is not satisfactory. This is why we need to do our best to improve research. One of the very critical points is the end point of any study to have a decision. And here we have solid outcome, which is patient death or organ death, renal failure. So if we wait until we have solid outcome, this will take long time. And we need interventions, we need research, we need to answer questions. This is why we can accept valid surrogate endpoints. So doubling of serum creatinine, GFR decline more than 40%, or within the slope reduction of estimated GFR. So these two criteria are considered valid surrogate endpoints. The reduction, GFR decline by 30% or urine albumin creatinine reduction by 30% are considered reasonable surrogate endpoints. When we use surrogate endpoints in any trial, it is wise to follow the patient within the within phase 4 and the post-marketing for refinement. We need standardized outcomes, and we have shown here glomerular disease and there is strong hemodialysis and strong transplantation. We should establish the core outcome to improve the research. If this is a situation in clinical nephrology and dialysis, I think the issue is more complicated in transplantation. Why? Because the first-year graft and patient survival is excellent, rejection is very low. So how to convince transplanters by new immunosuppressive drugs? It is quite difficult to run new randomized controlled trial in the field of transplantation. One of important point is it's better to promote placebo effect rather than nocebo effect. Nocebo means the side effects, adverse effects of the drug. Placebo means beneficial effect of the drug. So it's better to adopt strategies to promote placebo effects and to prevent nocebo effects. And we can prevent nocebo effects by double-blind technique, because if we run the study in open label trial, what happens if the patient knows the nature of the arm given and is aware of side effects? Now the patient will report excess side effects. So it is a very nice point to be considered. Let us go in a journey, in a tour with the most recent publications in the field of nephrology, dialysis, and transplantation. To start with clinical nephrology, I'd like to start with the domain of diabetic kidney disease. This is a nice study. They showed the correlation between the presence of carbohylated lipoproteins, especially HDL, and diabetic kidney disease progression. So in this study, it was proven that the the level of carbohylated lipoprotein increase with decreasing estimated GFR, and increased levels of carbohylated HDL are associated with future CKD progression, as you see here in the adjusted hazard ratio. This is one of the landmark studies. The credence, so credence is a study of using canagliflozin for treating diabetic kidney disease and putting renal as a primary endpoint. So this is the first study that put from sodium glucose transporter inhibitors trials that put the kidney as a primary endpoint. And it was prematurely terminated because of the beneficial effects. So these are the two arms, canagliflozin and placebo, and the canagliflozin was proven in this study to be beneficial for the kidney. We are waiting the results of DABA kidney, and I think it will be very exciting if it becomes positive. Why? Because in DABA kidney, this study included both diabetic and non-diabetic CKD patients. So we are waiting the results of DABA kidney and IMBA kidney. Both of them will add a lot to our understandings and to add the evidence-based management of using sodium glucose cotransporter inhibitors for treating the patients. Be aware, because sodium glucose cotransporter inhibitors to be used if estimated GFR above 30 ml per minute. Another diabetic kidney disease trial, SONAR trial, where atrasentan was assessed in type 2 diabetes patients with chronic kidney disease, SONAR, in a double-blind randomized placebo-controlled trials. And there was a running period, and then the randomization after the running period, to be sure that the patients tolerate the drug. And the drug was proven to be effective here in reducing composite renal outcome. So I think this is another addition in the last year for treating of diabetic kidney disease. Do we know or expect new studies? I think this review included the list of the ongoing studies in diabetic kidney disease. So we are waiting more and more studies to answer and to find the unmet need in diabetic kidney disease. This is a very interesting study, BERL trial. Why? Because it addresses a very interesting question. does the use of allopurinol as hypouricemic drug change the outcome of diabetic kidney disease in type 1 diabetes? And this study included large number of patients, and the design is very nice. So it is a very good study. Unfortunately, within the last renal week, in abstract form, the results were disappointing. So this is a negative study, and the use of allopurinol was not associated with any beneficial effect for type 1 diabetic kidney disease. Regarding supplementation, effects of vitamin D and omega-3 fatty acid supplementation on kidney function in patients with type 2 diabetes. So this is very interesting. Do these supplementations protect the kidney in type 2 diabetes? And this is the randomization. So we have vitamin D3 and omega-3. This is one arm. The second arm, vitamin D3 and placebo. And then the third arm is omega-3 fatty acid and placebo. And the last arm is to placebo. The results of this study, as you see here, there is no difference in any outcome of the kidney, either with the use of vitamin D or omega-3. So do they protect the kidney? The answer is no. So there is no evidence that supplementation of vitamin D or omega-3 make any significant difference. Another very hot and exciting, vitamin K2. It is rational when vitamin K2 is given, this will replete vitamin K, and by this way it may reduce vascular calcification as a rationale. However, this study, although it is of low power because each arm included 35 here in vitamin K and 33 in placebo, but look, the dose of vitamin K2 is 360 microgram per day for 6 months in comparison to placebo. And the patients were followed up by this PET scan and the CT scan. PET scan showed that the use of vitamin K was associated with higher calcification. But CT scan shows no difference between vitamin K and the placebo. If we take even the results of CT scan, treatment or the patient's diabetic with GFR above 30 with 360 microgram vitamin K2 has nothing to add. So I think we need an evidence because this is a double blind, although as I mentioned, it is of low power. A fantastic issue in a pilot study, the use of empagliflozin for patients with syndrome of inappropriate antidiuretic hormone. What happens to serum sodium? Empagliflozin, in addition to fluid restriction, leads to a higher increase in plasma sodium level compared to placebo in hospitalized patients with SADH. Why? Maybe due to its osmotic effect. Let us shift to lupus nephritis. I think this study is interesting, at least for me. This is why we have MD thesis, the same idea to address the value of protocol biopsy to guide us for withdrawal of immune suppression in lupus nephritis. So this is a study in here. The biopsy was done sequentially, up to 4 time biopsies. And this study showed that kidney biopsies done during maintenance therapy may help in deciding whether to continue or withdraw immune suppressive drugs. The rationale of this study is that you may find discordant between the clinical and the pathology. So if you have remission from the clinical endpoints and there is still active nephritis, I think we should wait until complete remission based on this study. We need further studies to recommend doing surveillance biopsies to guide the maintenance immune suppression. And this paper shows that we are waiting the many trials, ongoing trials in lupus nephritis, because there are a lot of unmet needs. So we have here the studies, all these are ongoing trial. Here, this is a human monoclonal antibody against type 1 interferon receptor subunit, blocking type 1 interferon activity. So, and this is how the study is designed, and we are waiting the results. Another study, pegylated synthetic cyclic peptide, bind to C3 and C3p, and this humanized and CD40, oral inhibitor of TYK2, iscalimab, human monoclonal antibody against CD40, obinutuzumab, humanized and CD20, and voclosporin in phase 3 study. So we have a lot to see in the coming years for the treatment of lupus nephritis. In Albor syndrome, here this is the study, a multi-center randomized placebo-controlled double-blind phase 3 trial with open arm comparison, indicates safety and efficacy of nephroprotection therapy with ramipril in children with Albor syndrome. So this is positive. Children between 24 months to 18 years undergoing care at 14 German trial sites. And here this is how the study was going in. And then early initiation of ramipril while the patient has hematuria showed no safety signals and no side effects. It's tolerated, and the preemptive therapy appears to slow early disease progression, and they may justify screening of patients with isolated hematuria for Albor-related gene variants. Another interesting point. Sometimes we have a case of glomerulonephritis, and we are in a mess. Is it because of post-infectious glomerulonephritis, or it is T3 glomerulopathy? I think this discovery of autoantibodies targeting factor B, which is a member of alternative pathway, adds a lot, because it is highly correlated with acute post-infectious glomerulonephritis. So if it is high with certain percentages of precision, the case is post-infectious glomerulonephritis. Treating ANCA-associated vasculitis, this is an open label randomized control study, addresses the issue, can we use mycophenolate mofetil in inducing remission for the ANCA-associated vasculitis? And the answer in this non-inferiority trials, yes, we can use mycophenolate mofetil for MBO ANCA, because in MBO ANCA, it is of less relapse, because here in this study, the time to first relapse is shorter with MMF, but it is effective in inducing remission. So we can use the MMF if we have MBO ANCA associated vasculitis. One of the very important studies, because this study included 700 patients at 95 centers in 16 countries, assessing the rationale of plasma exchange and glucocorticoid strategies in severe ANCA-associated vasculitis, where some of the patients had pulmonary hemorrhage. So these are the arms, 350 patients in each arm, plasma and no plasma exchange, and the same for steroid, either standard dose or reduced dose glucocorticoids. What are the results? If we look here, death for any cause, end-stage kidney disease, and the sustained remission, serious adverse events, serious infection at 1 year. Here there is no difference either to do plasma exchange or not. Here for standard dose glucocorticoids versus reduced dose corticosteroid is the same, almost the same like the standard dose, with less a serious infection at 1 year. This means that we should be wise in selecting immune suppressive modalities for the patients. And I think plasma exchange is needed if there is plus ANCA vasculitis, anti-GBM disease. But this study is a negative study for the efficacy of plasma exchange in patients with ANCA vasculitis. This is cablasizumab. This is antibody against von Willebrand factor, and it was proven in this double-blind randomized controlled trial to be efficient in thrombotic thrombocytopenic purpura. And the drug under the name of Cablivi was approved last year. The problem is the cost, because we need $270,000 for each episode of TTP. Regarding anemia management, this is the pivotal trial in hemodialysis. So this is hemodialysis, not clinical nephrology study. This is intravenous iron, multi-center open label randomized controlled study comparing proactive to give iron parenteral reaching sufficient iron stores, or reactive, we give iron when there is low iron stores, as documented by ferritin and transferrin saturation percentage. And in proactive, if serum ferritin increased above 700, the iron was reduced or discontinued. So as you see here, the proactive was superior to the reactive strategy. And here the primary endpoints, here again and again, the proactive is superior to that one. This is another study for nephro. This is in CKD patients. It is safety and efficacy of iron isomaltoside 2-ferric versus iron sucrose in patients with chronic kidney disease for nephro. So iron isomaltoside 1000 ferric isomaltose versus iron sucrose. This is an open label comparative trial in 143 sites, hospitals, private clinics, and clinical research centers in the United States. And this is the results. In patients with CKD, single high dose iron isomaltoside 1000 ferric D-isomaltose has comparable efficacy with fewer cardiovascular events compared to repeated doses of iron sucrose. So this is one of the studies in anemia. Roxadustat, hypoxia-inducible factor stabilizer, bromhydroxylase inhibitor. This is the phase 3 trial in China in CKD, not on dialysis. So here, in comparison to placebo, roxadustat was efficient to improve hemoglobin and in the same moment to reduce hepcidin. And this is good news, positive phase 3 trial for roxadustat. Regarding metabolic acidosis, because this is very interesting and very important and usually forgotten. And here, this is a systematic review about the trials for correcting acidosis. So either by sodium bicarbonate or by diet manipulation, bicarb was improved, and progression of CKD is reduced, and as well as end-stage kidney disease is reduced, but with the excess hypertension because we use sodium bicarbonate. Look here, this is here regarding the decline of estimated GFR, it is of moderate certainty that bicarb reduces progression, and here reducing in stage but with low certainty, hypertension, very low certainty. But again and again, if we use sodium bicarbonate therapy, it's better to advise for the patient to be restricting sodium chloride. Vivremer, I think this is an interesting drug because it binds HCl in the stomach. By this way, without exchange sodium, so there is no gain of sodium by using this drug. And in this study, This is the placebo randomized controlled study in blinded placebo controlled 40-week extension. This study was positive that this drug is effective in reducing composite endpoints. And we are waiting the results of more ongoing studies. So this is the study here, phase 3B, randomized double-blind placebo-controlled study to evaluate the efficacy and safety of this drug in delaying chronic kidney disease progression. And we are waiting the results by October 2022. This is regarding the FDA approval process. Vivremer here under the name of Trisida. Here in November last year, the Trisida announces, this is the company, announces FDA acceptance of new drug application for Vivremer, and they are expecting to have approval within few months. Hyperkalemia, it is very important. I don't like hyperkalemia because it's documentation in the file. If we don't treat hyperkalemia and the patient suffers a lot, this is of medical legal problem. So this is a supplement of NADT, and here you can find cocktail of articles about treating hyperkalemia from pathophysiology to treatment. So this is the summary of pivotal trials, meta-analysis, and the current guidelines. So we have traditional Kexalate and the newcomers, Batromer and sodium zirconium cyclosilicate. This, both of them are selective. So Batromer is selective, calcium-containing, sodium-free organic polymer. While sodium zirconium cyclosilicate, it is highly selective, sodium and zirconium containing inorganic crystalline silicate. Here you can read the mechanism of action, the route of administration, how they are site of action here in the colon, here distal colon, and here in the sodium zirconium cyclosilicate through the entire intestinal tract. And these are the most common adverse events. Here the conventional Kexalate, gastrointestinal intolerance, hypokalemia, hypernatremia, hypocalcemia, volume overload, and chronic necrosis. And this is because of, and it is considered serious adverse effects. For these newcomers, for Batromer, gastrointestinal intolerance, hypokalemia, and hypomagnesemia. Sodium zirconium cyclosilicate, gastrointestinal intolerance, hypokalemia, and edema. So these points to, this is regarding the new potassium binders. This is one of interesting study. The use of Batromer allowed the use of RAS blockade spironolactone for the patients, and this was a positive study. This is another study for sodium zirconium cyclosilicate in chronic kidney disease, phase 3 study. Irrespective to the stage of CKD, this new potassium binder was sufficient to reduce hyperkalemia. For dialysis sector, is there a difference between HD hemodialysis or in-center hemodialysis or peritoneal dialysis? This is a propensity score matched mortality comparisons of peritoneal and in-center hemodialysis. Systematic review and meta-analysis showed no difference between hemodialysis or peritoneal dialysis. This means that we should have both of them and then prescribe the modality that best fit with the patient needs and the characteristics. Is there a difference between medium cutoff versus high flux dialyzers? This is a crossover study including 20 patients in each arm, and these are the type of dialyzers. And this study showed clearly that the use of medium cutoff membranes allowed getting rid of middle molecule and myoglobin efficiently in comparison to high flux, but with the risk of moderate hypoalbuminemia. Again and again, roxadustat, phase 3 trial in dialysis, the same like CKD. In this study, they using roxadustat for anemia in patients undergoing long-term dialysis. We have here two arms, roxadustat versus ibutine alpha. The drug was efficient, associated with improving of hemoglobin and with significant reduction of hepcidin. Sodium zirconium cyclosilicate for reducing the incidence of pre-dialysis hyperkalemia for dialysis patients. So this is a very nice results that the patients on dialysis tolerated the drug and allowing more and more potassium control. So sodium zirconium cyclosilicate was an effective and well-tolerated treatment for pre-dialysis hyperkalemia in patients with end-stage renal disease undergoing the hemodialysis. The scenario of tenapanor, it is very interesting for me to use sodium hydrogen exchanger inhibitor that reduces phosphate reabsorption from the intestine. This is a randomized phase 3 trial. It showed clearly that tenapanor significantly reduced elevated serum phosphate, and even after discontinuation and withdrawal, it keeps an effect after withdrawal of tenapanor. The major side effect of tenapanor is diarrhea. This is why it is FDA approved for treating under the name of Epsirella for treating constipation, irritable bowel syndrome. But be careful because this molecule shouldn't be given to pediatric patients. Another interesting study for the anticoagulation in dialysis patients. Here we have 3 arms, either the warfarin targeting NR vitamin K antagonist targeting NR of 2 to 3, or rivaroxaban 10 milligram, or rivaroxaban fortified with vitamin K2. Withdrawal of vitamin K antagonist and high-dose vitamin K2 improve vitamin K status in hemodialysis patients, but have no significant favorable effects on vital calcification progression. So this is another negative point for the use of vitamin K2. Severe bleeding complications may be lower with rivaroxaban than with vitamin K antagonist. So this is, I think this is a nice study. Regarding this molecule, which is peripherally restricted and selective agonist of kappa opioid receptors, diflucaphaline, this is double-blind placebo-controlled phase 3 trial, addresses the efficacy of this drug against one of the distressing complications of dialysis, which is uremic-associated pruritus. And this is the number of patients in each arm, the placebo, and in this drug. And this drug clearly was efficient to reduce the uremic pruritus. Let us go to renal transplantation arena. So I'm going to start with this report about recurrent FSGS after kidney transplantation adults. Here, the problem is, and this is a Tango project, a large number of patients were screened, so 11,000 kidney transplant recipients were screened for the original kidney disease, and then the cohort of the patient addresses FSGS and S recurrence. It recurs in 32%, and treatment of the patients by, if it recurs by plasmapheresis plus or minus rituximab in the most of the cases, 21% complete remission, 36%, this is the number of patients partial remission, and this is the number of patients with no response. No response was associated with significant increased risk failure, graft loss 39%. So the idiopathic FSGS recurs post-transplant in 1/3 of cases, increases by fivefold, increases the fivefold the risk of graft loss. Response to treatment significantly improve the outcome of these patients. ABO compatible and incompatible transplantation. Where we are, this is meta-analysis, systematic review and meta-analysis, Lancet paper for 7,000 ABO incompatible renal transplant patients from 40 eligible studies using compatible transplantation, so compatible versus bio-incompatible for ABO. This study confirmed the inferiority of the outcome in bio-incompatible ABO system. So ABO-incompatible transplantation was associated with lower graft survival. So this is my point here. The best way is to encourage paired donation. What about mTOR inhibitors versus mycophenolate mofetil? This is systematic review and meta-analysis showed that both of them can work well. However, the rate of discontinuation because of side effects was more common in the mTOR inhibitor arm. The results, the 2-year follow-up of the Transform trial. In this trial, we have everolimus plus reduced calcineurin inhibitor in 1,000 patients in comparison to mycophenolate with standard dose calcineurin inhibitors. Here, the same as the first year, no difference between the arms regarding the proportion of patients free from events. And biopsy proven acute rejection, there was no difference between the two arms. However, BK and CMV, here CMV was clearly reduced by using the everolimus. If you look at any percentage in the total, it's 8.7% here in comparison to 20% here in mycophenolic acid users. So this is assuring data. However, there are many points in the Transform study heterogeneity, but it is a large randomized controlled study done in the field of transplantation. Do we have the best trial in transplantation? Is it the best? The rationale of this study is to assess, can we get rid of calcineurin inhibitor and steroids from renal transplantation? It is prospective randomized multi-center trial. Best mean, belatacept, early steroid withdrawal trial. So these are the three arms, belatacept and alemtuzumab, belatacept with ATG or ATG followed by belatacept, and then ATG with tacrolimus. So in comparison to ATG and tacrolimus, the use of either alemtuzumab or ATG plus continuing with belatacept, here the answer, there is no difference in patient graft survival, but with excess rejection in belatacept treated arm. My point up till now, I'm not convinced by belatacept. Yes, it is superior to cyclosporin, but I think it is not adequately assessed in comparison to tacrolimus. But at the end of the day, this is another armamentarium that we have to enrich the individualized treatment of the patient if we have it, but it's expensive. Regarding antibody-mediated rejection, I think interleukin-6 receptor antibodies are appealing, and we are waiting the results of the ongoing trials. Refinement of immunology of tissue typing from concentrating on big HLA antigen into the molecular. So here we can compare the epitopes of both the recipient and donor, and then we can know the mismatched epitopes, and then assessing the presence of antibodies on the beads or positivity here in the beads. This means that these epitopes are antibody verified. If we find here for the mismatched donor epitopes antibodies, this means that we have donor epitope specific antibody. So can we move from DSA, donor specific antibody, the traditional anti-HLA antibodies, into donor epitope DISA specific antibody? Here the results. If you apply the DSA versus DISA, you'll find here the risk is improved from 16% to 23%. So it seems that we are waiting innovation in immunology. I like AlloSure test because from rational point of view, although we need further studies, it was proven for antibody-mediated rejection because if we have rejection, the graft releases DNA in the serum of the recipient because the graft is belonging to the donor. So measurement of donor-derived circulating free DNA increased within the area of in the period of rejection. This is a very recent, just accepted study. It showed clearly that patients with acute rejection, T-cell mediated rejection, grade 1 or borderline, all these patients are either with low circulating donor-derived circulating free DNA or high donor-derived circulating free DNA. All of them had T-cell mediated rejection or borderline. And the results of this study showed that high level of circulating donor-derived circulating free DNA was associated with poorer outcome, increased antibodies, and affection of graft survival, to the extent the authors recommended to add it as to complete the endpoints beside biopsies. For AKI, one of interesting point, if we give treatments like ACE inhibitors and you find some increase in creatinine, is it, we should take it serious? So the question is it a relevant safety endpoints to find rising creatinine? And from the title, you can expect what I'm going to say. Stay calm and carry on here, because in both SPRINT trial and ACCORD trial, treating hypertension intensively was associated with rise of creatinine, but in the same moment, reduction of biomarkers linking acute kidney injury. So there is no problem. So if we have increased the creatinine, it's better to be wise. A blind clinical evaluation plus basic metabolic panel. And going all through this algorithm, and the main conclusion is clinicians should therefore think before acting so as not to deprive patients of potentially beneficial therapy, and we should search for concomitant etiology. Regarding the hepatorenal syndrome and acute kidney injury, this is a very recent review in the Nature Review Nephrology, addressing the reappraising the spectrum of acute kidney injury and hepatorenal syndrome in patients with cirrhosis. As you see here, we should review history, physical examination, laboratory, and images, and consider inferior vena cava diameter, removal of offender agents like diuretics, lactulose, non-selective beta blocker, NSAID, volume expansion for a couple of days, and to assess if creatinine is reduced or still increasing. And after that, we look at the blood pressure in the urine. So we may have the spectrum that it is not hepatorenal syndrome, it is ATN or acute interstitial nephritis, acute glomerulonephritis. So if we have hypertension, we think hematuria, we think of acute glomerulonephritis. If we have very low blood pressure, severe hypotension, we think of acute necrosis. And if we are here, this is either probable or confirmed hepatorenal syndrome. So we give the treatment and then assess the response here. If the patient is in stage 1, we give midodrine oral plus octreotide sub-Q, target mean arterial pressure rise by 50 millimeter mercury, and assessing a response. If there is a response, continue treatment for 4 to 7 days, and then a switch or continue midodrine. And then if no response, noradrenaline, and here in stage 2 or above, we give noradrenaline intravenous or telemedicine and targeting this blood pressure, and then stop if no response in 2 to 3 days. So this is the approach, and this review raised gaps and a suggested area of future research, including assessment of the role of serum cystatin C or other biomarkers in hepatorenal syndrome, integration of novel urine biomarkers, utility of ultrasound-based volume assessment. I like inferior vena cava diameter, and here inferior vena cava diameter, cardiac and lung ultrasounds. Using ultrasound, point of care ultrasound is fantastic. Intra-abdominal pressure through bladder catheters and measuring the pressure within the urinary bladder, etc. Let us shift to the most exciting part in this presentation, which is science and technology. The question, can we see fibrosis in the kidney without biopsy by radiology? This is very interesting, and you will find 4 articles within the Kidney International, 2 original articles and commentaries and digest. So they visualizing fibrosis, hope for ideal markers beyond imaging. So this is one of the modalities. It is collagen binding molecular probe, CNA 35, in combination with hybrid computed tomogram, fluorescence molecular tomography imaging, CT FMT. This is very nice. There is no gadolinium, it's okay, but the and this is the how it appears. But the second modality, which is more superior in detection of fibrosis by using gadolinium, EMSA, it is gadolinium-based elastine We can assess fibrosis without gadolinium, but it is not efficient like using gadolinium. So gadolinium-based elastin-specific MRI contrast agents, GD, EMSA, with moderate affinity to elastin, but weak binding to plasma protein. So it's superior to CT scan in this issue. The problem of gadolinium, I think it is not the nephrogenic systemic fibrosis, because I'm not recommending to use gadolinium if there is advanced CKD. Why I do it to assess fibrosis? It is usually the advanced CKD. But the problem is, if we want to follow the evolution of fibrosis by repeated gadolinium, I think there is a warning from FDA regarding gadolinium accumulation in the brain. The last point in this presentation is building research environment. I am lucky because I work at Urology and Nephrology Center, founded by Professor Renal, and with I am happy to work with this fascinating team, Professor Sobha and all professors and colleagues in this photo. In this center, we have more than 1,000 publications, and so we have the facilities and we have the environment established by the center. We got the experience at Urology and Nephrology Center, and we transferred this experience to Mansoura Medical School, and I am very proud that I coordinated the project of students to have research in summer, and these are 32 students. All of them participated actively in research. All of them went to Europe or United States to present their abstracts, and moreover, 8 articles were already published in PubMed indexed journals. And so this is how research is enhanced in this naive experience. And I am happy that in Faculty of Medicine, Mansoura University, we started to address the issue of evidence-based medicine from the early beginning for the first year and second year medical school. It is very important for the medical students to build flexible mind, because don't forget that medicine is a science of uncertainty. We need research, and we need how to read research, how to critically appraise the research, because not every paper is efficient to change our mind for treating the patients. This is one of the very fantastic event. This is a student in secondary school, and this was the summit of regenerative medicine from Mansoura Experimental Research Center in collaboration with the ESNT stem cell chapter. And this student had the closing presentation of the conference about the journey to the Egyptian mind. It was very interesting and fascinating, and the photo includes the 4 presidents of Society of Egyptian Society for and Transplantation. All these are youngcomers, and this builds a hope that we have human resources. And I would like to end with the superstar Professor Ahmed Zuhail, rahmatullah alayh, where Professor Zuhail put the statement, for research, we should have both seed and soil. We need the human resources who are willing to do and have full capacity, and they're willing to participate actively. So this is the seed, and soil, the environment and facilities and the grant. All of these are important. And I think the vision is important, because leadership is offspring of vision, as stated by Dr. Zuhail. At this point, I should stop. Thank you very much. Hoping you all the best. I'm happy because the ESNT this year is totally different. It is more and more successful. Hoping the best for our society and for Egypt and all of you. And if you have any questions, please don't hesitate to send your questions to my email. Goodbye. Hoping you the best.